Right. Well, maybe we can go ahead and get started, and then I'll just keep my eyes peeled if any others are able to join us today. There we go. Well, welcome. I am Allie Remacher. I'm a pediatric hematologist and the program director for pediatric hematology at Children's Wisconsin and the Medical College of Wisconsin in Milwaukee. I am also one of the members of the operations committee for NICER, which is the North American Immunohematology Clinical Education and Research Consortium. And I am here today with Dr. Boomeron. And do you want to introduce yourself as well?
Yes, I'm Laura Boomeron. I'm a pediatric hematologist at Children's Minnesota here in Minneapolis, and also part of the committee at NICER, and then co-chair specifically with Dr. Remacher on the NICER Communications and Empowerment Committee. We're excited to kind of talk about the world of immunohematology and what kind of careers can look like and what immunohematology is. So thank you everyone for joining us.
Yes. All right. Our agenda today, we're going to walk through lots of different questions about what is immunohematology, how does this relate to immune dysregulation, when should I think of an immune dysregulation disorder, what is the pathophysiology between immunohematology conditions, how do cases present, and really how can we incorporate immunohematology into a career. This is something that I didn't really know much about, certainly as a fellow, and although I had some training in different aspects of it, I didn't really picture myself as this career. And over time, I've been able to build a really cool immunohematology immune dysregulation program at my site. And so we're also happy to answer any questions about what that may look like as a career in the future. And then at the end, we're going to share with you a few different ways that you can get involved now, either as a trainee or as an attending level physician as well within immunohematology. Great.
Perfect. So diving into kind of what is immunohematology and what it entails as kind of a career. So we know that the immune system has three significant roles: one, to fight infections; two, to recognize itself from other or foreign; and then also to surveil for malignancies. And when we have problems in each of these areas, they can lead to different types of pathophysiologies. For example, if you have issues with fighting infections, you can have an immunodeficiency. If you have an issue in recognizing self from other, it can lead to autoimmunity and inflammation. And if there's an issue with surveillance for malignancy, there can be problems with lymphoproliferation and malignancy. So how does immune dysregulation apply to immunohematology? So I kind of break down what immunohematology is into a variety of categories. First, with having primary immune-mediated cytopenias, the most common being ITP or immune thrombocytopenia, autoimmune hemolytic anemia, and autoimmune neutropenia. And then a category of autoimmunity that includes things like lupus or lymphoproliferative and histolytic disorders. And another category of bone marrow failure syndromes, both inherited bone marrow failures versus acquired bone marrow failures or bone marrow failure secondary to myelosuppression.
Did it go through?
Yes, it did. Thank you.
There you
And then kind of the last part of immunohematology of how I break it up is that you can have immune dysregulation with immunodeficiencies such as CVID, CGD, or SCID as a clinical phenotype. So when should you think of an immune dysregulation disorder when you have a patient? So I think of things like clinical manifestations is if you have suspicious cytopenias that are chronic, that are recurrent, that are refractory, or that are multi-lineage, or if there's an early onset of these cytopenias, typically less than the age of 1, that don't resolve versus like a viral suppression that will resolve in a few weeks, or if there's other associated clinical manifestations such as lymphadenopathy or organomegaly or other systemic symptoms. So some type of past medical history that could be relevant in kind of assessing a patient with immune dysregulation is someone who has autoimmunity like type 1 diabetes, IBD, autoimmune hepatitis, or if they have recurrent infections like acute otitis, sinusitis, or skin infections and require multiple oral antibiotics or admissions for IV antibiotics. Unusual or severe infections, again, requiring IV antibiotics or multiple antibiotics. And then if there's a diagnosis of CVID or another primary immunodeficiency. Important family history to kind of raise a red flag is if there's a family history of autoimmunity, a known family history of an immunodeficiency, or a known family history of a cytopenia.
So now going into the pathophysiology of immunohematology. So I really like this figure because I think it helps kind of just separate all the different ways that we can develop cytopenias, especially in immune dysregulation. It does say PID here, but I think it can really translate more outside of just what we think of in the past as a primary immunodeficiency to more of these PIRDs, like immune regulation disorders or inborn errors of immunity. Lots of different vernacular changes over the past few years as we tend to learn more. So different buckets that we think of are autoimmunity, immune regulation disorders, myelosuppression, as well as bone marrow failure. First, jumping into autoimmunity. And so how this occurs usually is through autoantibody production issues. And these can be separated into intrinsic B cell defects, disturbances between the regulation and interactions of the T and B cells, as well as effector T cell defects. First, talking about the intrinsic B cell defects that can occur. So initially at the top, there's some sort of issue with our B cell and its function. This can lead to maturation impairment. We can have receptor checkpoint disturbances, which allows for development of autoreactive clones. And this can lead to autoreactive B cells as well as hypogammaglobulinemia. And so these B cell defects can go one of two different directions. Either we're producing too much and having really ineffective autoreactive B cells like we see in the condition of autoimmune lymphoproliferative syndrome or ALPS, or in the opposite direction where we're having development of these really abnormal B cells that aren't functioning well and not going on to make plasma cells that make antibody typically and having hypogam. And this can be seen in common variable immunodeficiency. When we think of disturbances between the T and B cells and these interactions and regulation, we think of a lot of this idea of loss of tolerance. And so we're supposed to tolerate ourself. We're supposed to know what's self and not self in our body. And when there isn't regulation of that, we can have loss of tolerance, and this leads to immune dysregulation and autoimmunity. So in the central sector, these are our lymphoid organs. So if we think of our thymus and our B cells, we start with these lymphoid precursors at the very top here. We initially have immature lymphocytes. If these are typical immature lymphocytes that are going to go on and be functional, they're going into the periphery, and you can see below we're having mature lymphocytes. However, if there is strong recognition of what would be self-antigen, and so targeting our own self, then there's three different things that can happen. One can be that we have apoptosis or deletion of one of these lymphocytes. Two, we can have change in receptors, so receptor editing, and this happens in the B cell compartment. And then the third thing that can happen here is we can develop regulatory T cells that are derived from these abnormal lymphocytes, and they are typically only CD4 positive T cells, and they go on to surveil in the periphery and help with elimination of autoreactive lymphocytes. So if we are in the periphery here and we have these typical mature lymphocytes, and these are in the peripheral tissues, if we are recognizing self-antigen, then again, we have a possibility of having apoptosis. We can have anergy, or this can be suppressed by the development of these regulatory T cells. And so any place along here that is not acting typically can lead to loss of this tolerance. And so if we aren't recognizing that these are abnormal lymphocytes that recognize self-antigen, then they go on to produce autoantibody, and that's where this process fails. And this can be either the T cells or the B cells because it's how they regulate one another. If we aren't having strong development of regulatory T cells and we're not having the suppression that's supposed to occur, then we're allowing these self-antigens through the B cells to produce autoantibody. And so really it is that interaction between the T and B cell that's also important in this sector. And finally, effector T cell defects that can occur. So in terms of effector T cell defects, we can have on the left, lack of T cells against non-self or foreign antigens that lead to autoreactive T cell clones that can attack self, as well as signaling defects. So this is deficiency again of those regulatory T cells, which we call Tregs, as well as poor development of autoimmune transcription factors, and that's that self-tolerance. We see this through T cell mediated autoimmunity. And so the thought is that anyone who's developing this autoimmunity, even if it seems like it's primary ITP that goes on to get better, there's probably something different genetically about those patients and those children. Not everyone's going to develop a primary ITP after a typical infection. So there must be something different about either monogenically or perhaps it's the interactions or epigenetics that we don't quite know enough about yet regarding small little changes in different genes that are probably reacting to one another. If we have a susceptible gene change or difference in a patient, and we lead to this failure of self-tolerance, then we have these self-reactive lymphocytes. Simultaneously in the environment, we're having tissue and injury and inflammation that's occurring all the time. And whether that is from an infection or just an injury or something else in the environment like a toxin or radioactivity, they're going on to having activation of tissue and antigen presenting cells. If we have activation then of these self-reactive lymphocytes from whatever trigger there is there, this leads to increased self-reactive effector lymphocytes, which directly lead to tissue injury through autoimmunity. Next, we're going to focus on the pathophysiology piece of immune dysregulation disorders. When we have immune dysregulation disorders, so some of these, yes, are kind of similar to what we talked about because they're all a little interrelated, but we can have these lack of function mutations. So we're not functioning correctly in whatever gene is helping with the immune system. So this loses to that, or this leads to that loss of self-tolerance as well as cytopenias. But we can also have different complications from infections, oncologic treatments, lymphoproliferative syndromes, and symptoms of primary immunodeficiency. And this can lead to pathologic macrophage dysfunction, functional natural killer T cell defects, and polyclonal or oligoclonal lymphoproliferation. And some examples of different disorders would be lymphoproliferative disease, which can be stimulated by Epstein-Barr virus, is kind of the quintessential virus that can kind of trigger this, as well as lack of invariant T cell receptor cells, interactive defects between the T cells and the innate immune system. So this happens in familial HLH. Nice big picture over on the right of a hemophagocyte. And key diseases to think about in these types of disorders are IPEX syndrome. And so this is the immune dysregulation, polyendocrinopathy, and enteropathy X-linked syndrome that we can see often presenting in infancy, typically of little boys, STAT5B deficiency, as well as macrophage activation syndrome, MAS, which is seen in our rheumatologic patients that have underlying autoimmunity, as well as secondary HLH to some other factor, which could be a cancer, an infection, or something similar. And ALPS is also a type of disease like this due to lymphoproliferative nature, where we're having a defect in that ability to apoptose self-reactive lymphocytes and getting that true lymphoproliferation. Next, moving on to myelosuppression. Usually what's happening in myelosuppression is viruses, most commonly. Rarely bacteria do this, but commonly it's a virus, and we're getting some sort of infection. The quintessential infections that we think of tend to be EBV, as we talked about, CMV, parvovirus, HHV6, as well as HIV and some others that will commonly cause these types of symptoms. Medication toxicity from antibiotics, immunomodulatory agents, malignant cells that are taking up space, nutritional deficiencies. So if we have underlying inflammatory bowel conditions, we can have poor absorption of nutrients, variety of different metabolic disorders that either take up space or don't allow for appropriate metabolism of different nutrients like vitamin B12, and wasting of vitamin B12, folate, or iron, typically from underlying GI disorders. Another really interesting way of thinking of myelosuppression is through myelokathexis, which is trapping of the neutrophils in the marrow. And this is typically a CXCR4 gain of function mutation, although there can be some other mutations that are seen, but this is in WHIM syndrome, where warts, hypogammaglobulinemia, immunodeficiency, and myelokathexis are all part of it. Not typically all of those things, but should be thought about when we have neutropenia, as those neutrophils are just trapped in that marrow shown on the right, and the marrow cannot release those neutrophils into the periphery. Other disorders to think about are bone marrow failure disorders. So some of these are typical when we have pancytopenia. We have to think broadly when we see these patients. So do they have a malignancy where we're having infiltration into the marrow space, or a precursor to malignancy, as in myelodysplastic syndrome, inherited bone marrow failure syndromes, so many, just a few to name: dyskeratosis congenita, Fanconi anemia, paroxysmal nocturnal hemoglobinuria, as well as Shwachman-Diamond syndrome, and acquired bone marrow failure syndromes like severe aplastic anemia, which intrinsically has some immune differences. That's how our IST typically works for those patients. And then, not to miss, but there are some primary immunodeficiencies that cause pancytopenia and should be thought about. Rare disease of immune osseous dysplasias, and then really interesting is Mono-MAC syndrome, or GATA2 deficiency, which has some autoimmunity and bone marrow failure component. So it kind of combines both of those things. How do we see immunohematology cases present in patients? So I am pretty lucky at Children's Wisconsin. We have developed our KIDS program, which is Kids with Immune Dysregulation Disorders. And there are several other institutions out there, many who are a part of NICER, who this webinar is brought to you by. So a lot of us are out there in multidisciplinary clinics, and we have the ability to see patients with lots of different specialists. So we have a gastroenterologist, we have a dermatologist, myself, a hematologist, bone marrow transplant, infectious disease. We have a genetic counselor, we have immunology, we have rheumatology. We even have a librarian come to our meetings to keep us on evidence base. And so it takes a whole village and team. And so I wanted to just present a couple ways in our clinic about how we have identified some interesting patients through journeys with multidisciplinary evaluations. Case number one is this sweet little boy who initially presented at 6 years of age with months of vomiting. He has underlying autism and a seizure disorder, and he was known to have some weight loss and a swollen foot. So you can see right here on the right. Sometimes his left side is also a bit swollen, but a lot of times it's on the right side. He had had some recent labs with another provider, I think his neurologist initially, that showed some macrocytic anemia. And then he saw GI first because he was having all this weight loss and vomiting. And he had a scope done that showed that he had chronic duodenitis and eosinophilic esophagitis. And so showing a lot of inflammation in his GI tract. His celiac testing, albeit having some of the symptoms of celiac, was negative. So this was not due to celiac disease. And then he had an ultrasound that showed that he had hepatosplenomegaly, so already suggesting maybe there's some underlying immune dysregulation going on. He still managed just by GI at this time, and 2 months later he presented and had severe watery diarrhea and worsening weight loss despite all of this. So he had some labs obtained, and so we can see his CBC, and we note that his white count is actually pretty okay overall. He didn't have a neutropenia or lymphopenia when we looked down at the differential, but he had a mild anemia where his hemoglobin was 10.4 and his MCV is on the higher side of 97. He also, I don't have all the labs here, but did have a widened RDW, and his platelet count was a titch low at 122. So as a hematologist, when I'm looking at that, I'm wondering a few different things. Okay, so he's got a macrocytic anemia. Could this be from a nutritional deficiency? He's definitely has some GI symptoms, so are we having some of that weight loss? RDW is kind of wide, so are we having some poikilocytosis, some anisocytosis that's driving that a little further? And his platelets are a bit low. Is that because his spleen and liver are a little bit big, or is he having immune-related destruction of those platelets, or is this watery diarrhea causing suppression of all these lines? So lots of things to think about with that. When we go on to look at his complete metabolic profile, his ferritin is 267, so a little bit on the higher side, nothing too crazy, but certainly not iron deficient. So iron deficiency isn't causing that hemoglobin likely unless he has a lot of inflammation. Albumin is 3.4, which is okay-ish, but once he was hydrated, because he was actually quite dehydrated with these labs, so you can imagine that his counts were probably a bit lower, but it was 2 once he was adequately hydrated. So he's got low albumin, so losing a lot of protein through his gut, and normal transaminases. He ended up having a colonoscopy done, and it showed severe active ileitis and moderately severe active colitis, and so he has colitis of unknown etiology. He was started on enteral nutrition and had complete resolution of his diarrhea. He was really not gaining weight very well, but his diarrhea did seem to improve. And then he had a trial of steroids, and this did help his labs overall. So his anemia a bit and his GI symptoms got better. And then he tried a few different antibody-mediated medications for his colitis. So this was infliximab and adalimumab, and he had steroids with it as well as methotrexate, and developed antibodies to all these drugs. And so from a GI doctor standpoint, so my colleague was following this cute kiddo in his clinic and was like, why are we developing so many antibodies? It just is kind of unusual even for their complex patients that they see. Over time, over the next few months, he develops rampant autoimmune hemolytic anemia. So probably that little bit of macrocytic anemia was actually his cells being broken down. Now, he was not being followed by hematology at the time, so I don't have good retic counts or a DAT or anything before, but he definitely hemolyzed down to a hemoglobin of 6 and had a high retic count and positive DAT, and it was consistent with warm autoimmune hemolytic anemia. He continued to have poor weight gain and growth despite having lots of formula supplementation. He had a G-tube in place, so he wasn't having to eat. And with his neurologic differences, some of that was difficult for him. And he developed leukopenia and thrombocytopenia and thought that he had sort of an Evans syndrome background as well. So these are the different things that are going on with him. So he has atypical duodenitis. So he doesn't have celiac. He's asymptomatic. He has atypical colitis under the age of 6, unusually asymptomatic, although he has this colonoscopy finding that is early onset colitis. He has hepatosplenomegaly, but when we look at his liver a bit more, he doesn't have hepatitis and normal vasculature. He has autoimmune hemolytic anemia, which is very uncommon in IBD. Despite the number of patients they see, they typically don't have concurrent immune-mediated cytopenias. And then we are getting antibody formation to lots of our biologics. So maybe with a level of inflammation, but it does seem extreme. And then he has leukopenia and thrombocytopenia. And although he has some splenomegaly, it seems a little bit more than that. And so the thought is perhaps this patient has Evans syndrome. So he initially had some genetic testing that was done. So he had an InVitae gene panel. Now, this was several years ago, so it's not the expanded panel that there was today, and it was normal. He had a test done for congenital disorders of glycosylation, which was negative. He had a whole genome testing that was initially read as normal. However, a few years later, when he developed the autoimmune hemolytic anemia, we wanted to do a reanalysis. And so our team got a hold of the raw data from the genome and reanalyzed it. And on that repeat analysis found a variant in FAS, which disrupted a splice site. And with all of the cytopenias that were happening, we opted to get a bone marrow biopsy done around the same time that we saw this. And lo and behold, although he didn't have any in his periphery on lymphocyte subsets, he did have double negative T cells, which can be seen quintessentially in autoimmune lymphoproliferative syndrome, which is typically a condition that is seen with a FAS mutation where you have lack of apoptosis. We opted to do additional testing, looking for different factors that could be confirmative of an ALPS diagnosis. His soluble FAS ligand was significantly elevated, and we did multiple FAS-mediated apoptosis assays, and they showed abnormal cell losses. He also had typical cytokine derangements. IL-18 was significantly elevated and had vitamin B12 that was significantly elevated as well, all looking like he actually has a diagnosis of ALPS. So, could this be ALPS? So, very unusual presentation of ALPS. On the left, supportive. He has splenomegaly, he has autoimmune hemolytic anemia, he has failure to thrive, he has a FAS variant, he has an abnormal FAS ligand level, he has double negative T cells, albeit in the bone marrow, but there, and he had abnormal apoptosis assay. So if we look at some of the criteria that's published, he fits that criteria. Not as supportive is diarrhea, enteropathy. Really, colitis is not typically seen in ALPS, but can be, I guess. And then peripheral double negative T cells weren't there. Seizures and autism, not typically related to that, so hard to know. And no clear other lymphadenopathy outside of the spleen, which is typically present in about half of the children. So in ALPS, how does it typically work? So we have mutations that can occur in these Cas bases as well as FAS and FAS ligand. And so what it is a non-malignant lymphoid hyperplasia. You get accumulation of autoreactive T and B cells both, and you developed immune-mediated cytopenias typically, and solid organ involvement is really uncommon. Often it sees autoreactive immune-mediated cytopenias, splenomegaly, and lymphadenopathy that's seen. And it does have an association with an increased risk of secondary malignancy, typically both types of lymphoma. So then it came to be, what should we do for treatment? So steroids, sure, he had some response, but that's not really ideal for long-term management. Mycophenolate can cause diarrhea, and he already has issues with GI complaints. Sirolimus is a very well-known medication that is an mTOR inhibitor that inhibits activation of T and B cells by reducing sensitivity to IL-2. Can cause some diarrhea, but it does help a lot in ALPS. Or a bone marrow transplant, which seemed a little bit excessive because we were able to kind of manage him a bit with steroids at the time. So he's on steroids for the autoimmune mediated cytopenias and things, but we're looking to move to something more long-term that can be helpful. So ultimately, we decide to treat him with sirolimus. And he started that a few years ago and is completely in remission from his colitis. And his cytopenias are very well controlled on the medication. He has limited side effects to it. Now, you may be wondering about this foot that I mentioned at the beginning. So why does he have the big foot? Well, he actually has another gene mutation and has it's lymphedema that is completely unrelated to his ALPS. So lo and behold, he won the genetics jackpot by having multiple genetic conditions, neither of which are associated with autism or seizures. Another patient that I have known for several years is case number 2. So this little girl initially presented at 3 years of age with splenomegaly and had severe worsening anemia with a hemoglobin of 6.4. She was known to have, without confirmatory testing, but there was a familial autosomal dominant hereditary spherocytosis underlying everything. But her labs showed that she had an elevated LDH, reticulocyte count, and a positive DAT test, which was IgG negative and C3 positive at the time of her initial presentation, and was thought that she perhaps had cold agglutinin syndrome. She had a bone marrow aspirin and biopsy done at the time of her diagnosis that showed a normal cellular marrow for age with erythroid hyperplasia and myeloid maturation arrest, most consistent with autoimmunity. She was treated initially with warmed red blood cell transfusion and a 6-month course of prednisone until she was in remission, and her hemoglobin was back to her baseline. Unfortunately, 6 months later, she developed worsening DAT-positive anemia. She had immunoglobulin panel, an ANA test, and PNH studies that were normal. She received 3 doses of rituximab that were stopped early due to anaphylaxis associated with a pre-medication prior to dose number 3. Ultimately, it was found that she is allergic to one of the components of liquid Tylenol, but she didn't get all of her doses of rituximab. She ultimately ended up with pancytopenia and had a repeat bone marrow that was very similar to the previous, so looked like pan autoimmunity. She was treated with prednisone and MMF for 3 months, and then her care was transferred and she to actually my current institution before I was here. And she had a confirmed diagnosis of HS through some additional testing like band 3. But they ended up stopping her immunosuppression because they were unsure if it was helping or not at that time. Unfortunately, a few months later, she presented to the emergency department with stroke-like symptoms. She had severe DAT positive, which was now IgG positive on the DAT negative panel, so looked more consistent with warm autoimmune hemolytic anemia. So very interesting, her IgG would not come positive on a typical panel, only on the DAT negative panel that was done here locally in the lab. Her hemoglobin was 1.4, so almost, unfortunately, could have died from this condition. The stroke-like symptoms were because she wasn't perfusing her brain. She had an abnormal ultrasound with an enlarged liver and spleen. She had recurrence of pancytopenia with an ANC of 90 and platelets were 115, and again was treated with prednisone for 3 months. 15 months later, she had recovered, and 15 months later, unfortunately, developed worsened pancytopenia with a hemoglobin of 5.3, platelets were 28, and ANC of 400. She got a blood transfusion, bone marrow, hypercellular, trilineage hematopoiesis, no congenital erythropoiesis. Due to insurance, she then transferred care to me when I was at a different program, and she had worsening anemia that we really couldn't find DAT positivity, but we started steroids and sirolimus. She responded really well to that, and she had hemoglobin 9 to 12 during that time, and normalization of her neutropenia and thrombocytopenia, was able to be weaned off of her steroids. When I met her, I did a really thorough family history. So her mom was healthy, her sister was healthy, she had a paternal uncle with HS, a paternal grandfather with HS, her dad had HS, and 10 lifetime pneumonias. And I just thought, I knew it. This is really abnormal. Dad, what is going on? So we sent him promptly for an immunology referral because I told him, even though he was in the Army, that didn't mean that he should have 10 pneumonias. And it turns out he actually had a diagnosis of common variable immunodeficiency, and these were his immunoglobulins. Initially, he was just monitored, but he developed severe cellulitis with a hospitalization, and then subsequently was started on monthly IVIG. So in summary, at this point, I had a 9-year-old, just 3 years later, who had autosomal dominant hereditary spherocytosis and recurrent, 6 years because she was 3 when she was first diagnosed, severe immune-mediated pancytopenia dominated by warm autoimmune hemolytic anemia, so she has Evans syndrome, and a father who has a diagnosis of CVID. And so kind of thinking like, are these related possibly? So Evans syndrome, so this is a combination of multilineage immune-mediated cytopenias. It is highly associated with relapsing refractory courses and immune dysregulation disorders. And so it can be a symptom of ALPS. And one paper showed that up to 50% of ALPS patients have Evans syndrome and can be associated with predisposition to CVID. Luckily, the French have a different medical system than us and can follow every single patient. And so they have a really good cohort of patients with Evans syndrome. And they put out a paper a few years ago that showed that 65% of patients who had Evans syndrome in their cohort had an identifiable monogenic disease. So there are many genes typically associated with inborn errors of immunity. So these are the genetic results that we got back. So on the top, we see, okay, for sure we have hereditary spherocytosis due to ankyrin 1 mutation that her father also has. However, we also had some interesting ones. We had LRBA, and LRBA deficiency can be associated with both CVID as well as lymphoproliferation and autoimmunity. Interestingly, though, this is an autosomal recessive condition. She has a VOS from her mom and from her dad. And so in my mind, I'm thinking whatever she has, her dad has, because how could they not be related? So this was a little bit of a surprise. So we ended up sending functional testing. You can send to Nationwide's immunology lab. They have a really good diagnostic immunology lab that does this testing for you, and it was normal. We actually sent her sisters as well. We did some testing, and her sister had one of these mutations, and she had normal testing too as a control. And then she has this NF-kappa B2 mutation. Now, NF-kappa B2 can be associated with lots of different things, and it was classified as possibly pathogenic / VOS. And so we actually worked with NIH, and they used their prediction tools, not her actual blood, and thought maybe it was benign based on where it was on, not located at the C terminus. And so very much can fit some pictures of NF-kappa B2, so we haven't completely eliminated it, but often those patients, you also have to think of diabetes and some other endocrinopathies that can develop, which are not consistent with the phenotype, but there's that. So I moved, and she unfortunately, just before I left, stopped responding to sirolimus and had to restart her on steroids. About a year later, she transferred care up to where I am in Wisconsin, and we kind of started over. What can we do? So we trialed MMF and rituximab, and we just didn't have a substantial response. And her spleen, unfortunately, was getting bigger despite it having to improve before. And we really struggled because we were like, is she going to be immunodeficient or not? We don't know. Should we do a splenectomy in this patient? She has HS and autoimmune hemolytic anemia. So ultimately, we decided to go forward with it because we just weren't getting good control. And she had complete resolution of her anemia. Now, she did get rituximab during this time, and she had had some lower IgG levels, but over time they just never recovered, and she did develop a diagnosis of CVID. She no longer has any cytopenias, but she does have consistently low IgG, IgA, and IgM, and she is on chronic IVIG, so her and her dad go together to get their infusions each month. So this is what happens a lot in this. The reason I put this one on here is because we don't have a complete confirmatory diagnosis because there's still so much to be learning, and this is the life of immunohematologist. We do our best to look at the specifics of the patients. I didn't put up all of her lymphocyte subsets and cytokines, but certainly has an aspect of T cell dysregulation that is influencing B cell production in this patient. And that's why we went on to utilization of MMF and sirolimus. That worked for a little bit for her. But I think what happens in some of these patients is with Evans syndrome, we get so much ramping up of their immune system and all this autoimmunity, and it just kind of peters out, and we end up with CVID later on, which has been seen in lots of different patients. So there is that. All right, so let's move on to how we can incorporate immunohematology into a career.
So a little bit about what medical specialties encompass immunohematology. And I think we can all agree that it is a vast, vast field with many subspecialties. And here is a list that we kind of came up with, whether you're hematology, oncology, BMT trained, immunology, allergy, genetics, infectious disease, rheumatology, pathology, transfusional medicine, GI, cardiology, dermatology, or pulmonology, all can have involvement in immunohematology and can be very helpful to have that training and that background in a multidisciplinary clinic. So what training do you need to pursue a career in immunohematology, both with having an MD or DO, a PhD, PharmD, master's, bachelor's, really any type of training or educational background, I think, can be applied to the world of immunohematology since it's very multidisciplinary. And then kind of breaking down what into three kind of very raw categories. What can a career in immunohematology look like? It can be something that's more clinical, where you're seeing patients, you're a part of or running a multidisciplinary clinic with other subspecialists and navigating challenging cases. It can be research-based, whether that's clinical, translational, or basic science. Or it can kind of be something more related to patient support groups, such as Race for Immunology, or our industry partners that we work very closely with as well.
I would say a huge benefit of this career too is the ability to work and collaborate with so many different people. I think for me, there's always like those special patients that kind of trigger you to like move into this space. One that I can think of is I had a little baby who was 3 months old, and he had had thrombocytopenia his first month of life, got better, and developed severe thrombocytopenia at 3 months of age. And when I met him, I found out his dad had all this infectious history. His aunt was on some infusions for infectious issues each month, which ended up being IVIG. And we did really early immune assessments and genetic testing, and found a PI3K kinase deficiency that early at 3 months of age. And, that's amazing. And so it took a lot, though, to be able to talk to others. You want to surround yourself by other people who have interest in this, because you truly need a multidisciplinary group to fully understand these patients as we are learning more and more about them. And the benefit, too, is that this is pretty niched. And so there are partners that you find at lots of different institutions. And so it's been a real treasure to meet others at many different places, and even starting out, reaching out to those people to try to develop your own program, so that you can provide really advanced care for patients in your area. It's such an interesting thing to do. And so being able to develop that expertise and have a multidisciplinary approach for these kids that often are undiagnosed or having difficulty with treatment can be really rewarding.
So kind of looking at how you can become more involved in immunohematology, I think there are many different facets. One, of course, is NICER, attending our annual meeting, which is coming up in September in Ann Arbor. NICER also hosts virtual education camps, which are, I think, an incredible resource for trainees, as well as faculty and other disciplines to kind of learn from. And then we also have NICER patient case conferences to go over cases. We have something called the NICER Unhide program for those cases that are puzzling and troubling, where we kind of work and collaborate together to think about next diagnostic steps to help in a diagnosis. And then we also have a pretty robust research program through NICER. And that's a QR code to register for our NICER website. And some other national organizations and meetings that encompass immunohematology, including the Clinical Immunology Society, their annual meeting. There's also the CIS Summer School, which is really helpful in kind of a diagnostic approach for new trainees or freshly graduated, or someone who just wants to kind of have a refresher of approaching some of these complex patients. ASPHO, there's an annual meeting every year. Next year, it is in Montreal. And there is a clinical immunology special interest group at ASPHO. ASH has their annual meeting coming up in December in New Orleans. And then ICON, which is the ITP Consortium of North America, but has encompassed a lot more, I think, than ITP as it has kind of matured and developed. And there's an annual meeting that they have at ASH, as well as part of the PDSA breakfast at ASH through ICON.
Another note about NICER as well is the website does show who are institutional members of NICER. And so if you go to the website, you can see if your site is an institutional member. And if so, you get access to a lot of the additional things that a member institution would, like participating on the research studies. However, a lot of these things are just available. So the education camps, the patient case conferences, there's a whole YouTube channel for NICER that you can look look at past I want to call them episodes. I know that's probably not right, but meetings or conferences that go over all of these things. And the annual symposium is really great because it's a nice way that marries both education, and there's always like a really cool topic. And then Evelyn, who is on here, makes it the most beautiful conference that you've ever attended. And it always is based off of literature and is just lovely, put together with so much thought. So I always get so much out of it because I still have so much to learn, and in ways that I hadn't even thought of before. And then you get to just see also what kind of amazing research are people doing out there in this field. And it's really, truly multidisciplinary. There are geneticists that are truly like world experts there. I learned so much from rheumatology, immunology, bone marrow transplant, all sorts of people. And we really encourage trainees to come. There's even some abilities to get some funding to attend the conference as well if you are a trainee. And so I would definitely encourage you to look into joining us in September. And it's in Ann Arbor, which is home to NICER. We wanted to give an opportunity here. I think there's about 10 minutes left. If there's any questions, feel free to put them in the chat if you'd like, that we can answer, and whether about what you can do now, anything that was discussed, or if you're working on building an immunohematology program at your site or would like to do something like that in the future. Happy to answer any questions on that, as I went through it a couple times so far.
And if there's anyone who has particular research interests, we can always work to connect you with different groups within our research committee, and let you know of any projects that are ongoing that you might be interested in.
Our information on here too. And then the QR code at the bottom of this one is for our education piece of our website, but you can of course like scroll through any of it, and that will also take you to the registration link for the symposium that's coming up. But we're here. A lot of times I have complicated patients. I reach out to my colleagues, and I know we're both very happy to help with any complicated patients that you may have, or direct you in the right direction if there's something that you need assistance with, or just want some career advice. All right. Well, if there aren't any questions, I guess we can end a little bit early today. Thank you so much for attending today and for your time. We really appreciate all of you joining us. And let's see. Oh, one other question. You're starting with that. Oh, Megan Cooper. That's great. The bone marrow evaluation, patients with immune cytopenias. Do you see a particular pattern that we would consider is hypoproliferative marrow expected? So that's an interesting question. So I think really early on in some of the immune-mediated cytopenias, we can see that there is poor production as well. But most commonly with an immune-mediated cytopenia, we often will see more of a hypercellular marrow or a normocellular marrow. And so that hypoproliferation is a little bit difficult to completely understand. And I would say that I have seen it sometimes early on in a course, or a patient that's been heavily treated with immunosuppressants, but commonly when it's a new diagnosis, often we'll see more of a hypercellularity. And I would suggest that I don't get a marrow on like every patient with ITP, for example, because unless they're really difficult to treat, or every even autoimmune hemolytic anemia patient, but if they become more difficult to treat, or that you have a multilineage cytopenia, often it's a good idea to get the marrow just to see if you can get any additional clues from tissue. Often tissue can be really, really helpful in these conditions. So that can be a good place to start. And then if your patient by chance has lymphoproliferation, often, or enlarged lymph nodes, neck, axilla, groin, getting a lymph node biopsy at the same time can be helpful, because sometimes then you can see a little bit more where are those, again, sites of dysregulation, knowing that there are going to be a lot of patients that you may not get a monogenic finding with. Yeah, great question. Well, great. Yeah. Thank you, Shipra. And I think that you texted me the other day and I forgot to text you back. Sorry about that. How did I get department leadership to support this clinic? Selling points. Yeah. So this is something that you definitely want to get buy-in. And I think that a huge thing that has helped is that there are not a whole lot of these programs out there for immune dysregulation disorders. So I think there's a couple things where I've been able to be successful. I think one is finding partners in other divisions, and also just identifying patients that you cross over with other departments. And kind of really the selling point is that your time to diagnosis, your time to patient-based management is significantly decreased when you do a multidisciplinary program, whether that is a clinic or meetings or something where you have partners. I think it's a huge selling point because a lot of institutions are moving towards like these collaborative multidisciplinary clinics. And I think when you can show that this is better for the patients won't have to come, to multiple visits on different days, or that the patients are going to be able to get a comprehensive evaluation. That's very attractive for a patient too. And it can be a great selling point and way for your institution to really promote something that's unique that most places can't do. And also that it's better for the patients overall. And so I think those are huge selling points for it. And then totally agree, having partners in other specialties. And so I think that it can be helpful if you already have an idea of who are the people that you've worked with in other divisions who have maybe some expertise or interest. That's kind of a no-brainer. But also working with other division chiefs has been helpful to just identify who they see as someone who may be able to fill that void of looking for a partner that can kind of grow with you and develop that expertise and move forward. There are some partners that I have in our group, like pulmonology and neurology, where there is like a neuroimmunology like piece of everything in immune dysregulation, and we have a separate program for that. But I do have a neurology partner because I've had some patients who have had some tick-like symptoms or other things, and it's good to have a partner to rely on. So they may not come to clinic all the time, but just kind of, asking the division leadership of like, hey, I'm trying to expand. I want to partner with you. How can we move this forward? We've also been able to, another issue that sometimes comes up is appointments. And so how can you, do different appointments because like you're in a certain space, and where is the clinic housed, and like how can everybody get reimbursed and things like that. And so I think it's working with also the administrators of different divisions to make sure that everybody is getting their appointment slots separate, so that everyone gets reimbursed separately for that. And so when the patients get their appointments, when they come to my clinic, often there'll be like 3 or 4 appointments that are listed, but they come to one site and they see all the individuals as a team. And I know Shipra had a question for me before about getting funding to be a member of NICER. In case any of you are attendings, there is a institutional fee to be a part of it, and that the benefits of it are of joining NICER that way are being able to have access to being part of all the programs that are offered, but especially the research base of it. And because these patients are so rare, doing multi-institutional research is really important because your patient populations otherwise end up being really small. And we have at NICER a lot of partnerships with lots of different places, even with genetic testing and working on a registry and working on all this research. And so you have access to that, and that's just good for your hospital too. And it's a well-funded organization that through philanthropy and other ways. And so I think that being able to sell on, being able to have that ability to publish, to do research in a space that is rare and interesting and that people are trying to learn more about is really important. If I was starting a program with three specialties, what I prioritize, I think, and Laura, you can speak for yourself too, but if I would say three, I would say hematology, immunology, and a genetic counselor or geneticist. If you can get a geneticist, it's hard sometimes because there's not so many of them and they are spread very thin because they do metabolism off. I certainly have a geneticist partner, but I have a genetic counselor in my clinic with me every time.
Yeah.
Laura, I don't know. Yeah, I think those are most important. I cross over a lot with dermatology, GI, and rheum, but we, and have partners there and try to coordinate things. Bone marrow transplant too. I mean, that's in my division, so that's not so hard. But luckily, most patients don't have to go to transplant. But in terms of the like GI and rheum, we're working on, so we have our partners there, but we're working on having like we do 2 clinics a month. So we're working on having like a clinic every other month with one of those specialists so that, because our huge thing is what I like to do in my clinic is go in all together. So I do often have a trainee with me. We like our fellows to be able to have an experience to learn about these patients. And so often there may be a fellow that goes in, and then I go in actually simultaneously with everybody. Now, I don't always stay for the full genetic counselor talk piece of it, but she stays for ours because it's really important for her to kind of hear. And then I've learned so much from immunology doing it this way because every specialist asks questions in a different way. And I find it really beneficial so that we all are kind of hearing the same thing and then all kind of making sure we're describing things in a patient-friendly manner. So great. Awesome. Well, I know we're 1 minute left, so that filled up nicely. So if there's any more questions, please reach out. I started a similar program at my prior institution as I did here. So I've had a lot of experience in kind of building some of these things and happy to answer any questions that people have and can also point you in directions of those who help me. And everyone in pediatrics, of course, is so kind. So it's really easy to reach out to these people. So thank you again so much for your time. We really appreciate you and look forward to hopefully connecting with some of you in the future.
Thanks, everyone.